স্যার আমরা লাইভ আছি, আপনি বলুন, শুরু করুন।
আচ্ছা। So, good evening, everybody. This is our second webinar on tumor board. One of the most important topic to be covered by the Postmortem Orthopedic Association. And thanks to him, he's arranging everything. And this is the area where we can learn many things new from him and his team. And today also, this night also, we also learn many things from the cases presented. So with these few words, let us start the program. Partha is busy somewhere.
Yeah.
Thank you, sir. And
Kaushik,
our
Lalit Mani sir has joined.
স্যার এখন জয়েন করেনি,
আচ্ছা
জয়েন করেনি। আমি ফোন করলাম, ফোন ধরলো না, লিংক পাঠিয়েছি স্যারকে।
আচ্ছা, অল রাইট, তুমি স্টার্ট করতে পারো, ঠিক আছে, আস্তে আস্তে করে স্টার্ট করো।
we have started. Actually, we are online, and Chinmay sir has also given the welcome address. So, as our secretary, Dr. Partha Sarkar is at Bahrampur. We all know about our member Dr. Navaran Shah. He has got sudden PIA attack. So we all wish him a speedy recovery. So our secretary is there and helping, and all possible help from our side. So I will request Dr. Kaushik Nandi to start the symposium on the scientific session.
Dr. Jyoti Prakash will start with the first presentation.
Jyoti, you can share your screen.
Okay. So as when Jyoti will be sharing, so I will request everyone to be on mute. So after the discussion, whenever he asks any question or opinion, so all can unmute themselves and speak.
Am I audible and visible?
Yes, perfect.
So, good evening, everyone. Today, first of all, as you already told, we listened a very sad news regarding our colleague Navarun. Very deep, saddening news, and I pray to God for his complete and the full recovery at the earliest possible. Thanks to WBA and all the tumor estimating for this webinars. Right now, I will be discussing a single case of litigation in distal femur. So, patient was 27-year-old male who was jobless for 3 years, though he was mason by the profession. He had the operation twice 4 years before in the distal femur for the tumor region. At present, he presented with a painful, swollen, stiff knee with range of motion from 20 to 60 degrees. So this is the X-ray. I will like to invite Dr. Arif, our honorable radiologist, to throw the light. Arif sir.
Yes, thank you. So we have a lighted kind of expansile lesion in the distal femur involving the epiphysis and metaphysis, and as well extending into the diaphysis.
Arif sir, you are not audible. Please
Okay. Am I audible now?
Yes. Right now.
Okay. So we have X-ray of the knee joint showing a lighted lesion, which is expansile, and the lesion is having some internal trabeculation as well, and there is destruction of the destruction of the posterior cortex of the distal femur as well, and the lesion is quite well defined with narrow zone of transition, and we have some evidence of previous operation with some bone cement and the screw, and I suppose I can see some lesion in the proximal tibia as well. Am I correct? There is some moth-eaten kind of lesion in the proximal tibia.
Yes, sir.
Is it there in the tibia? I can. So I think it is a multicentric lesion.
Okay.
For me, if for me the lesion of the if I am for me the lesion in the femur appears to be the benign sort of lesion, showing bony expansion with narrow zone of transition and all. And but then the lesion in the tibia, I can't explain why there is a lesion in the tibia. So do you find anything in the tibia on clinical examination? Hello.
Sir, your voice is very low.
Jyoti,
Sir.
Hello. Hello.
Yes.
Yes, sir. We can hear. Jyoti, we can hear. I think you can increase your sound or something because we can hear him.
Okay, just listen.
Hello.
Yes,
Am
yes.
I audible now?
Yes, sir. You are audible. You are fine. No problem. You can go ahead.
Okay.
Meantime,
Okay.
any other comment from any other Ananda or Kosikda, you can add something or.
Can we see the previous X-ray with I mean the X-ray before the operation?
In addition to that, we have the previous X-ray also available. As you can see, first X-ray is first before intervention. First X-ray,
Yes.
then watching.
Yes.
Then
This
the
X-ray is more.
picture.
Yeah, this X-ray is more important now.
Yes, sir.
So the lesion in pre-op X-ray appears to be still well defined, but there is some amount of the periosteal thickening along the lesion. Yes.
Actually, in
along the
the
lateral.
can I say something?
yes, sir.
In the first slide, the X-ray in the AP view, though it is narrow margin, short margin, but in the lateral view, probably there is much more extension over the medullary canal of the femur. But from the initial picture, it appears to be giant cell tumor. But in this picture, it is a recurrence of the giant cell tumor with a little more aggressive in nature. And in the tibia, probably it is because of the disease atrophy.
So nothing in the tibia, huh?
Disease atrophy.
Honorable Professor Lalit Mani sir has joined us from MMC. Welcome, sir, for the WBA bone tumor registry webinar. Sir, do you have any suggestions from this X-ray images?
Thank you, Kaushik, for allowing me to join. And yes, my thoughts are actually similar. It appears to be a lesion which is there since 2014 and looks like a giant cell tumor. And now the recurrence is a pretty aggressive one. So we need to treat it as a recurrent giant cell tumor. However, would still like a core biopsy to confirm the diagnosis.
But then the periosteal action was initially there as well. Okay.
I'd like to know, actually, is there any history of radiotherapy or not?
No, sir.
No, it's
No, not adaptation.
okay then.
Dr. Kaushik, would you comment upon the mode of fixation? What was done in
my question to Dr. Arif.
Pardon?
Dr. Arif, what will be the next best suitable investigation before proceeding with the core biopsy?
I think an MRI should be done for this patient. Actually, the lesion could look quite, the lesion could look well defined, sort of with narrow zone of transition and all, but still there is some amount of periosteal reaction along the lateral cortex of the bone. GCT usually don't have periosteal reaction. Can you make out the periosteal reaction sort of along the lateral cortex in the initial X-ray? So
Yes.
it is for me it is an indeterminate sort of lesion. So I think an MRI should be done.
But when there is a implants inside, don't you feel there will be much artifacts from the implants, metallic artifacts?
Yes, there will be some artifact, but still we will able to see. We will able to make something from the MRI about the nature of the lesion.
Do you have any special sequence, sir, for like a metal artifact reduction sequence in this kind of scenario? Metal
Exactly.
artifact reduction sequence.
Yeah, we do have some metal artifact reduction, metal artifact reduction sequences, but the implant are so big, it will have some problem with the MRI images. The images will be not that good, but in our hospital we have done some MRI with this kind of implant, and then we are able to make something from that MRI from those MRI. Regarding the nature of the lesion. So we try to have MRI even with these kind of processes. As you know, we do MRI for this with these processes, and we are able to make something from those MRI in indeterminate sort of lesion like this. The low grade chondrosarcoma should be ruled out for this patient, or osteo as well.
So any role of PET scans are here? Do you think any role of any PET scan?
Not exactly. First, we should note the nature of the lesion, then we can advise accordingly.
Okay. So before going to the further investigation, any comment on the mode of fixation? What was tried at that earlier time?
From radiological perspective, am I audible?
Yeah,
yes.
Yeah, from radiological perspective, for all practical purposes, it looks like a benign sort of lesion, but then we have, but still, I'm not convinced with the periosteal reaction along the lateral cortex, and there's some amount of fluffy sort of periosteal thickening along the lateral cortex. That is raising a bit doubt regarding the diagnosis of the GCT. So I will go for one MRI for this patient before taking for the operation.
Dr. Arif, just see the destruction in that tenure of 1 year from 2K14 to 15. The loss. Just a minute. The lytic lesion area increased so much. Do you think was in favor of the benign lesion? The amount of lysis.
Yes, the pattern of the in 2015 X-ray, the pattern of bone lesion is still benign sort of. There is eggshell margin of calcification around it. There is no aggressive bone destruction. The new lesion that has developed along the medial femur is still a sort of benign sort of. There is no aggressive destruction of the bone. It is more of the expansion. So it is still not that aggressive.
Okay. So, Professor Pal, sir.
It is. I think it is recurrence of the giant cell tumor. So it is benign till now.
Okay, sir. Sir, will you like to comment on the fixation? With whether the two-screw cashless screw which has been shown here is sufficient for the fixation point, orthopedic point of view?
Actually, fixation, definitely it is only to uh, strengthen the bone if there is any fracture, pathological fracture. So it is adequate. It was adequate. When you are applying bone cement, then this screw definitely sometimes it will work, but otherwise even it is quite stable.
Possibly who will? So this is the present scenario. So as our radiologist told, we will go for the MRI. We advised for MRI, but our imaging center they refused because of the implant. So next PET scan was done, which revealed the metabolic active malignant lytic lesion of distal femur with extra cortical extension and distal femur lateral condyle also. So at this scenario, what should be done?
Jyoti, what is the histopathology images?
Actually, we don't have that images. Just a biopsy. Sorry for I don't have images. Then corneal biopsy was done, which came out to be GCT and in grade 3.
In the corneal biopsy, we do not give any grading, and I think anything grading is not the pathological grading at all.
Yes.
So, can you show the images, please, of histopathology images?
Histopathology.
Yeah.
Slides.
Slides. Histopathology slides.
So taking the as a diagnosis of the GCT with recurrent GCT, how should we proceed?
Jyoti, can you listen, Jyoti? Hello.
Can I say something?
Sir.
Yes, sir. Please, sir.
I would still try and insist and try get an MRI, because it is very crucial to know the extent of the lesion, both intramedullary as well as the soft tissue breach posteriorly, because I need to take a very, very aggressive decision. With looking at this X-ray, it appears that most of the condyles are involved. If you see carefully, the medial condyle of the femur, probably some amount is just left 1 centimeter next to the joint, but then rest of it whole is involved. Your lateral condyle is totally gone. There is a breach. Now I can't make out whether it is medial, lateral, or both. So try and insist on getting an MRI, but if you still fail, maybe a CT scan itself, a high resolution CT scan with 1 mm cuts, so that you at least get to know the extent of the breach. Because the decision is going to be a very, very important one, which is going to be between repeat curettage and salvage of the joint versus a resection orthodesis. So that's why I need to have some images, either a CT or an MR at least, to know the extent of this lesion. Kaushik?
That's MRI or plain MRI, sir, for this case?
Yeah.
Contrast enhanced MRI or the plain MRI for this case?
I would normally leave it to the radiologist. I would just ask for a maverick which decreases the artifact. This part of the decision is rested upon the
a contrast MRI should always be preferable for this kind of lesion. Contrast or non-contrast, the artifact will be same for both the studies. Either we give contrast or not. But I think the contrast should be done to look for the any soft tissue and enhancing soft tissue basically from where the proper biopsy can be taken. So contrast.
Another important detail I am interested in is the intercondylar notch area, which again seems to be breached here. So if all these details are available, it just clarifies my thought that I am not going for a salvage. It will go for a resection after this is most probably.
Sir, in the first place, as seen from the fixation, sir, am I audible, sir? Hello?
Yeah.
Yeah, as we have read in the textbook, this crisscross pattern of the screws and the parallel pattern orientation of the screws, do they really make any difference in preventing the possibility of pathological fracture or intercondylar supracondylar fracture as written in the textbooks? Do you have any experience, sir, in this case?
These concepts were there. If you go by this patient, 2014, maybe it was acceptable. It goes by the concept of the architects. If you use plain cement and if you use cement with iron rods inside, the strength changes. So that was the basic concept which was used to use screws with cement. However, in the current knowledge, there are two main problems. One is the subsidence of the cement, and the second thing is the fracture occurring later on at the cement bone junction. So it is a difficult decision to take whether to plate or not. So when there is a lesion which is extending into the metaphyseal or the metaphyseal diaphyseal area in a giant cell tumor, you know that there's going to be a big stress riser. And more often than not, now the recommendation is a cement with plate actually. Okay.
Can I question? Have a question? Can I hear?
Yeah.
Can I audible?
Yes, sir, you're audible.
My question to Jyoti also and from the radiologist, from beginning, it is from radiology, it is not a clear-cut picture of giant cell tumor. It's not looks like a giant cell tumor. And MRI, we cannot able to do that MRI. So from only the cold needle biopsy, which is also not sure in this case, it is a giant cell tumor. So then what other scenario? Without going proceed to wide dissection, yeah, we again go for the open biopsy or some sort of thing. Because radiology is still not clear. From X-ray, there is a period of still reaction. The X-ray is doesn't looks like a classical GCT, and MR we cannot able to do that. And your PET CT is also high SU value as mentioned here. So why not it should be put towards the malignant issue? Either repeat biopsy, because your clinics, your radiology and your biopsy will not match with each other, what I think.
For this, I would like to ask about Professor Pal, sir.
In biopsy, the report is giant cell tumor. In King's grade 3, it is radiological grading, but it is giant cell tumor. But grading is not mentioned. But from the radiological picture, it appears to be little more aggressive. And the intramedullary, I wonder whether there is any intramedullary extension or not. That is one important issue. MRI definitely to be attempted, to be tried again.
At least
histopathology.
Sorry to interrupt. At least we can look.
Histopathology is showing giant cells. The only confusion could be that is it a giant cell rich osteosarcoma? That could be the only apprehension before taking a decision. So there could be two ways of doing it: that you get the same review, or you looking for some special stains for it. However, for osteosarcomas, we don't still have very strong special immunochemistry stains. But for other tumors, that could help. So the zoom of the slides to specifically look for malignant cells converts it into a malignant type of a giant cell tumor, which is now more or less treated as a osteosarcoma.
Exactly, sir. Basically, the one thing should be ruled out is a giant cell rich osteosarcoma here.
Yeah.
And it is basically morphological diagnosis. So histopathology images is very essential for confirming.
In this scenario, the slides and blocks from the previous surgery, because the index surgery, the entire lesion was curated. So if the specimen from the previous slides and blocks are available, that can be taken for review.
Yeah. Yes. Exactly.
Do we have Tapan Maitra, sir? Tapan Maitra, sir, am I audible? They not there?
Jyoti, you. Jyoti, you proceed with your case.
Okay.
I think.
So if the second histopathology expert also is non-conclusive, that makes it a case of a repeat biopsy.
Okay.
That could again be a core biopsy, but it should be in good consultation with the pathologist.
So now we have the management option. What to be done? Whether to go for the recurators after biopsy,
We are assuming it's a giant cell tumor.
Pardon?
We are assuming that it's a giant cell tumor recurrence.
So whether we go for the recurators after biopsy or we go for rejection in the modular endo processes, or also what are also told now to go for the rejection arthrodesis. So what is the better option? Many sir.
And in this case, your
Yes, Anand, continue.
Tell me, manager, how would you like to proceed, sir?
Okay. Whatever information we have would be a resection arthrodesis.
Rejection arthrodesis.
The query still remains in my mind. What if the post-resection biopsy comes as a malignant tumor? So that apprehension remains there, because in a resection arthrodesis, I'm going to take away probably around, say, 9 to 10 centimeters of bone, and I would need to reconstruct it by taking a fibula or some other grafts. So since this apprehension is there in my mind, my resection would be wide, and probably I'll not do the bone grafting in stage 1. I'll use a long nail and I'll use a cement spacer. And once I get the histopathology report and I'm clear, I'll use the muscular technique and come back at 3 weeks and do the bone grafting.
Yes, sir. Dr. Garg.
I go for the resection and endoprosthesis because the clinics, radiology, and even biopsy, and your cortex is breach, and even intercondral area, and intramedullary extension all along that. So, taking consideration as a malignant this disease, I go for the wide dissection and definitely with the modular endoprosthesis.
Basically, you want to go for the mobile joint, and sir, value manager wants to go for the stiff joint.
I'm very choosy about a giant cell tumor. I very, very rarely do endoprosthesis. My philosophy is that a giant cell tumor patient will not succumb due to the disease.
But
I want to do a procedure which lasts his life, and I assume that any endoprosthesis in a giant cell tumor will fail within, say, 7 to 10 years. And the patient is going to be of a second, third, or fourth decade age group. So we're going to face a lot of revisions. So I'm very, very choosy about endoprosthesis in giant cell tumor. Of course, if we are sure it's a malignant tumor, the options change.
But sir, as
actually, in this case, recurators has minimum scope, though it is the treatment for the recurrence. But in this case, it is not indicated. Now the question is between the resection and endoprosthesis. resection and arthrodesis is preferred, but it should be the consideration, the opinion of the patient and his need, her need. That is very important. But resection and arthrodesis would be probably more beneficial for this patient in this particular scenario.
Dr. Kaushik, what is your opinion?
I'll be asking Professor Lalit Mani sir. Sir, you have a vast experience of customized 3D printed implants in this case joint reconstruction scenarios. So, frank malignant the osteosarcoma, chondrosarcoma in this case. So do you have any experience, sir, in this case of joint reconstruction with 3D printed models?
Oh, if it's a osteosarcoma, you will definitely go for a modular endoprosthesis, specifically around the knee. And if it is not a very young child, you don't need a customized solution. The available modular endoprosthesis would give an answer. And distal femur is invariably not a problem with the available implants. So Kaushik, you need to commit resection, arthrodesis, or endoprosthesis.
It's a biopsy proven straightforward GCT. I will go for as Professor Pal has also described in discussion with the patient, both pros and cons of the arthrodesis and knee arthroplasty. I will go for arthroplasty, sir. Resection and endoprosthesis reconstruction.
So if you discussed with the tumor group, the IMSOS group, they call arthrodesis as a non-biological solution.
Yes, sir.
It's very interesting. Arthrodesis is a non-biological solution, and endoprosthesis is a biological solution. So there is a conflict of thought process between the young generation of tumor surgeons and the biological old age tumor surgeons.
So arthrodesis will be truly speaking, arthrodesis will be a solution, for the lifelong solution for the patient. If it's a benign tumor, it's a GCT, as you have told, the patient will not succumb to the disease, but may succumb to the implant failures. If you do a muscular technique after confirmation of the final histopathology and the muscular technique is successful, bone grafting is incorporated, then it will be a solution for the lifelong. That is true. And for GCT patient, he will be most probably a survivor from the disease, and the patient may undergo 2 to 3 revisions for the implant failure. That is true, sir.
So any one of you has faced a revision of an endoprosthesis due to aseptic loosening, not due to fracture of the endoprosthesis, due to aseptic loosening of endoprosthesis after tumor resection. It is a totally hollow shell, proximally and distally. And the first revision is a nightmare.
Since we need to have an entire set of cement extraction that is supplied by the depot instrumentation in the OT, in your armamentarium.
So don't be shy on doing resection arthrodesis in giant cell tumor recurrences.
Yes, sir, definitely.
Sir, my question to Mani sir, whether this resection is from X, it seems to be at least 10 centimeter. And it's 10 centimeter is whether the masculine technique is successful in about the 10 centimeter gap, section gap.
Yes. If you look into the literature, the technique for bone tumors is described more for pediatric age group, and it is described for tumors which are in the range of 8 to 15 centimeter. You will not find a huge amount of literature on adults. Now, this is an adult patient. However, we have been doing this for the last at least 20 years with a long nail and muscular technique for the last 5 years. But even without muscular technique, using fibula, patella, and the iliac crest, and it's a fairly successful procedure.
Thank you.
So for achieving arthrodesis, we will put a nail inside intramedullary device or a plate?
No, it's a long nail from the tip of the trochanter till the supramalleolar area. It's around a 70 to 75 centimeter nail.
Nail means Kunsha
Interlock
nail. Interlock nail. Okay.
Interlocking.
So I'm sure you've done a endoprosthesis in this patient.
Oh yes, sir. So this was what was done. tumor. And this is the affected region. You can see the clear margin was taken out. This is the post-op X-ray, immediate post-op X-ray. Sir, what you will say, sir? Many, sir.
Looks good. The most exciting thing would be the biopsy rather than the post-op X-ray. It's done well. A good wide resection has been done. The implant is well aligned. The cementation looks to be good. But the exciting part would be the biopsy report.
Exactly. What does the histopathology report, Jyoti?
From the malignant DCT tumor.
GCT malignant means?
Means giant cell rich osteosarcoma.
Malignant variant.
Okay.
This is a GC, giant cell.
It's a giant cell rich osteosarcoma then.
Kaushik, throw some light on that. What is the meaning of a giant cell tumor which is malignant?
GCT malignant, I think it is not the correct pathology word basically, sir. They should use that it's a malignant GCT, it's a malignant giant cell tumor, or it's a giant cell osteosarcoma. I can't make out exactly. Any images are
having the potential for lung metastasis, it is still considered benign.
Yeah, exactly.
The GCT, if it's a malignant, then it's a malignant. It's a spindle cell sarcoma or a giant cell rich osteosarcoma.
So I will insist upon my pathologist to please again relook whether any osteoid is seen in any sections. It tells me whether it is actually an osteosarcoma or a spindle cell sarcoma. This is very important because we need to decide the post-op chemo regime.
Because the giant cell can be present in lots of tumor, including the benign and the malignant. So the only present of giant cell does not mean it is a giant cell OGS. As the SAT said, just saying that the malignant osteoid, the coarse lacy osteoids should be present there to call something giant cell osteosarcoma.
For GCT, what staging workup do you recommend before, if it's a GCT state for GCT, before proceeding with the surgery, definitive surgery? CT scan of thorax, bone scan, or simple chest X-ray. What is your protocol, sir? Professor Mani, sir.
If it's a primary GCT which has not been intervened, I will assume that it will not metastasize because giant cell tumors are known to have lung metastasis in 3 to 6% only post surgery after intervention. So in a GCT workup, I'm more interested in the local extent rather than the systematic. So I would be more interested in a local MRI rather than anything for a metastasis. So chest X-ray would be included for a normal workup for surgery. However, it will not be a major part of the staging workup. Kaushik?
Let's proceed. So we started the ROM exercise immediately post-operatively, and partial weight bearing was started from third post-op day. And at the final follow-up, there was a bit terminal restriction on the extension, as you can see in the photographs. Okay. Tapan Maitra sir has joined us.
What are the surgical scar mark on the lateral part? Like a pin tracks of the external fixator on the lateral side. These two.
did you cover the biopsy, code biopsy remarks?
Maybe the biopsy scar.
Yeah.
Have you referred the patient to the oncologist for the systemic therapy? Considering the diagnosis as a giant cell with osteosarcoma or a malignant GCT, you need to confirm the diagnosis, and if it's a malignant GCT,
You'll have to refer.
has to refer to
You
for the
will have to,
systemic
because it
therapy.
is for.
Yeah.
And it becomes important now to stage it for systemic spread. Now
Yes.
that it is malignant, you need to have a CT chest to see whether there is anything in place. So
For
that
the
will
matter, they have already done the preoperative PET CT have done.
okay.
This was the end of the first case.
Yes, Jyoti, you can unshare your screen. Stop sharing. Yes.
Yeah.
অনেকটাই বেশি বলুন টিআইএ নয়
Yeah, Kaushik, we can proceed with the second case.
Yeah, Dr. Garg will take over. Dr. Garg.
Anand, please share your screen.
Okay.
Dr. Anand Kumar Garg.
It's okay. I am visible.
Yes, but share your screen.
Yeah, already
Your
share my
slides are not visible.
Okay.
No, first open your PowerPoint, then click on the share button. You will see the PowerPoint in window. Then share. There is a button on the right side. Yeah. Dr. Tapan Mehta sir has joined. Welcome, sir. Welcome, Lalit Mani sir.
Namaste.
Now we have a very good oncology team, ortho-oncology team here in Kolkata, sir. Kaushik, Anand Garg, Jyoti, they are doing very good musculoskeletal oncology work here.
Nice.
I am proud of them.
Yes. Yes, Anand. Make it as presentation mode.
Yeah.
Fantastic.
It's okay?
Yeah, it's okay. You are audible also.
Yeah. So I'm going to present one case that is a one type of female patient, 40 years female, presenting with a progressive painful swelling of the knee joint for last few years. And
Garda, unmute yourself. Ananda, unmute yourself.
hello.
Yes. Start again. Yes.
The 40-year female presented with the painless progressive swelling of the knee joint for last few years. On examination, the temperature is normal and tenderness all around the knee joint with effusion, and range of motion is around 10 to 90 degrees. This is the skydiagram of the patient, and any comment from our radiologist and panelist, because from me it is a normal skydiagram. Anything abnormal in his opinion? It seems to be normal.
Dr. Arif, you can unmute yourself, then talk, please.
Kaushik?
Yes, sir.
Hello.
In the
Hello.
Yes.
Am I audible?
Yes,
Yeah,
yes,
yeah,
you
yeah.
are
you
audible.
are audible, please.
Please.
Yes, basically the diagram looks very much normal, but I but there may be some subtle sort of sclerosis in the femur, the distal femur, right here, if I am correct.
So I'm not wasting too much time. I come to the next and I advise for the MRI.
Anand,
Right?
can I say? Actually, in the lateral part of the metaphyseal region of femur,
Yeah.
there is some irregularities, periosteal irregularities.
Okay.
Exactly. Lateral along the lateral cortex.
Okay. So
In the
not the
AP view.
okay.
Yeah,
Sir.
this part.
So not wasting my time, I go for the MRI of this patient, and these are the MRI picture of the patient. So opinion from our radiologist in panel. These are the MRI picture available for our discussion. These are another MRI image.
Dr. Garg, what is the age of the patient?
30
Age?
years, around 30, 40 years.
40.
Yeah.
Okay, so nothing in the bone. Bone looks absolutely normal, but we have some amount of soft tissue along the posterior knee joint, along the posterior cortex of the femur, of the distal femur. Still the cortex is intact, and there is no continuity of the lesion with the bone. Am I audible?
Yeah, yeah.
Yeah. Okay. So can we have some more MRI images?
Yeah.
Okay. So
now you can able to see the sir. There is a proximal tibia. There is a bone involvement. The proximal tibia.
No. Yeah, in the proximal tibia there is some. Some in the epiphyseal region.
Yeah.
Few lesion are there, but then we have extensive soft tissue lesion around the joint. Okay, you can see in the along the posterior cortex of the femur, along the posterior joint cavity behind the posterior cruciate ligament, and some more some more lesion there as well. We have few few lesion in the epiphyseal region of the tibia, but then this is not a bone tumor. So it is mainly the signal, and coming to the signal intensity of the lesion, these all lesions are mainly hypo-intense on T1 and T2 images. These are T2 images. The most of the lesion is hypo-intense, and you can have some more lesion in the suprapatellar recess as well. Okay. So the lesion all along the joint without involving much of the bone, except for the few small lesion in the epiphysis of the proximal tibia, and all the lesion are showing T1 T2 hypointensity. That means it is some sort of fibrous lesion or some some blood product lesion. So this is basically PVNS, pigmented villonodular synovitis.
Yeah. So my question to Kaushik and Professor Mani sir also, from X-ray, MRI, and clinics, it seems to be what the sir so said. It is a case of PVNS, and this PVNS, then how to proceed for this patient? Whether you go for any biopsy, yeah, go directly for surgical intervention. Kaushik, Professor Pal, and Professor Mani, what's your opinion about this?
Also.
Actually, biopsy is to be, of course, histopathological diagnosis must be made.
Sir, sorry to interrupt you. Sorry to interrupt you, sir. The lesion is very much specific, and MRI diagnosis is quite, specific of this lesion. I don't know. Still, we would like to have biopsy, but
Another section, yeah.
Yeah, only if it is myositis ossificans traumatica, then only biopsy is contraindicated. Otherwise, biopsy is to be done. As the situation is not that, so biopsy is to be done.
Just one thing that also I want to add, sir, there is an entity called the malignant PVNS also. There's an entity called malignant PVNS, and which shows there is a atypia, mitosis, including atypical mitosis, the necrosis, all the features of malignancy are there. So, so not only the benign PVNS, there are some entity called malignant PVNS. So, core biopsy is required before any definite management.
Thank you,
Professor Maini, what's your opinion?
I think this is the easier part of the question. The difficult part of the question is once the biopsy report comes. So definitely we're going for biopsy. On the history, if we go, it is a long-standing history. So we get some idea about the biological behavior of whatever it is. So it is there for a few years. So your thought process would tilt towards the villonodular sign.
Kaushik, okay, we go for the biopsy as all the panelists is agree for that. What type of biopsy you go for that? Core needle biopsy under CM, whether USG guided, whether CT guided, what sort of biopsy we will do? Because as the volume said, where our plan is changed. If it is malignant PVNS, your plans will be totally changed with the benign PVNS, what I think. So biopsy must be there because MRI picture may be benign and malignant will be almost, it looks like T1 and 2T is dark images, what the studies told. So malignant and benign PVNS, you have to be confirmed before the proceeding any intervention. My question to Kaushik.
Oh, sorry. I will prefer for under CT guidance, under the guidance of radiologist, to the most solid component of the lesion to get a CT guided biopsy, needle biopsy.
From where? Soft tissue?
From the soft tissue, because as Dr. Arif has also component of intraosseous component, the major bulk of the neoplasm is in the extraosseous soft tissue component, and after discussion with the radiologist, which is the solid component, which may be the most representative part, that part I will intend to target with the CT guided needle.
Okay. So as sir told, this is a classical picture. T1, T2 is dark. It is a classical of PVNS. So management plan says first the diagnosis confirmation and the treatment model. So
I have one question, sir. I have one question. Am I audible?
Yeah.
Yeah. My question is to Dr. Arif. Sir, do you have any specific? Is there any specific clue from the radiology, maybe X-ray or CT scan or MRI, that can differentiate or can give a clue whether there is a malignant transformation or any clue between to decide between the benignity and the malignancy of the nature? Apart from the clinical history, benign will be a long-standing history. Because as Demal has mentioned, malignant PVNS as an entity, there are two types. It may be a malignancy from the day one, benign PVNS, which has changed its character into a malignant PVNS, which behaves just like a malignant spindle cell neoplasm. These are the two types of malignant PVNS.
Malignant PVNS has a long history also. So from history duration, you cannot go for the differentiating point.
Yeah, that's what, because the first type of the malignant PVNS is from day one, and the second type is it has set in a already benign PVNS that has changed its character. Then the history will be a long-standing history, and after some inadequate intervention also it can change its character. So my question is there any radiological clue by which you can differentiate? There is any? My question to Dr. Arif, sir.
Hello.
Yeah, my question, Dr. Arif, is there any specific radiological clue by which we can differentiate the benignity or malignancy of the nature in case of PVNS?
Not exactly. There's no. I mean, there is no specific radiological signs of differentiate between these two. We need to rely on the biopsy only.
Dr. Deepak Rachudis has joined us, sir. Do you have any comment in this case, sir?
This is a clinical radiological case of PVNS, sir.
Dr. Deepak Rachudis, sir.
Can you hear me? Hello.
Sir, you are audible, sir.
Okay. So, is there any harm of going for a biopsy?
Hello.
Hello.
Yes, sir. You are audible.
Yes, sir. You are audible.
My question is whether any problem.
You have to. Sorry, you have to increase the volume a bit. Increase the volume.
Okay, I don't know. Now is it all right?
Yes, sir.
Now I just want to know whether any problem of going for a biopsy.
No problem, sir. What we conclude also, biopsy must be done before any proceeding.
Yes. So I don't think there cannot be any question before going to biopsy.
Okay, sir. So I proceed next, sir. So this patient, as usual, presented with the medial correlations, and already the arthroscopical sinus biopsy was done from arthroscopically, and that is comes as a diffuse PVNS benign. So Kaushik, whether there is any harm in doing arthroscopical biopsy for your prognostic part or treatment part?
Arthroscopic biopsy is not recommended at all, because if the final specimen comes out to be synovial sarcoma or malignant PVNS, then we are already contaminating the joint. We are contaminating both the intra-articular and the extra-articular compartment. So the resection margin, morbidity of the surgery, and everything will increase. There is a biopsy principle. We should always avoid the joint. We should be away from the neurovascular bundle. If it's possible to avoid the joint, we should always go extra-articular.
Yes. So one of the messages from this case also, what we usually do, we go for the esophageal sinus biopsy many times in this type of cases. So before proceeding, we must go for either CT or UST guided percutaneous biopsy is one of the better to confirm the diagnosis. I proceed with, already I got the report before proceeding. So I did this surgery in 2 stages as a combined stages, because no one modality of treatment is best for recurrence and surgical mortality. I go for 2 stages, arthroscopically intra-articulate clearance of the PVNS, and then second procedure after 2 weeks for the posterior open extra-articular section. These are the first stages, arthroscopically view of the PVNS, and this is the complete and extensive sinectomy through the anterior and posterior portal. Next, first MRI, after first stage, I do the MRI again and see the big lesion on the posterior part of the tibia, and I go for the posterior extensive sinectomy with the PCL. I take out the PCL from there and curate all the tibia from posteriorly, and again fix the tibia with the scope. Histopathology confirms the PVNS of the variety. I give him the follow-up in 6 weeks, range of motion, and follow-up for 6 months. There is no significant complaint, but still beware for the further future recurrence. So this is a little bit discussion. Any question or opinion regarding this case from our panel?
At present, what is the range of movement of joint?
Actually, I didn't put the follow-up picture because recent follow-up is not better, but the immediate after surgery, after 2 to 3 weeks, it's more than 90 degrees. So there is a problem with the range of motion of this patient.
And next, we have to keep an eye and have to follow up whether there is any recurrence or not.
Yeah, definitely. I go for second case. So can I proceed?
Dr.
Yeah.
Before proceeding with the second case, Dr. Rajudri sir was telling me that he has a few issues with the fast case. Can we just discuss a few questions? We were a bit late.
No, nothing to say anything, but from the X-ray, it shows that there is an intra-osseous extension.
Sir, is not
voice
audible.
is not audible, sir.
Sir, either increase the volume or if you are on your laptop, lean forward.
And what I am to say, if we see the X-ray before operation, pre-operative X-ray, is it audible now? Is it audible now?
Yeah, yes. It's audible.
It has seen that there is extension of the intramedullary extension.
Yes, sir. It is confirmed in the MRI. It is intermediate extension in the tibia part also.
And next, there is also cortex break posteriorly as well as laterally. Okay.
I saw the X-ray, sir.
And there is also breach of cortex posteriorly and laterally. I think I am not audible. Okay, now go to the next case.
Is visible to all?
So you proceed for
Second case is visible to all?
I think I am not audible. So you proceed for the next case.
Osik, can I proceed for second case?
Yeah, sure.
So this is a case 21-year-old female presented with the mild pain and progressive swelling of the right wrist joint for last 5 months. This is X-ray. Radiologist from our panelist, his opinion regarding the comment on the X-ray.
There is one lighted lesion in the distal aspect of the radius with associated soft tissue and extensive destruction of the bone. The soft tissue is quite large, and we can see the zone of transition is not that well defined. It is a malignant lesion. It looks like a malignant lesion, and considering the age of the patient, it may be osteosarcoma. Lymphoma is also a possibility.
Sir, as we all treat, why not is, sir, from radiological, it seems to be giant cell tumor.
There is extensive destruction of the cortex. I mean, you cannot see the cortex of the radius on the ulnar side. There is complete destruction.
Because from clinics, age of the patient and site of the lesion and character of also match with the giant cell tumor. Yeah, definitely extensive destruction is there. But what I think GCT must be first diagnosis.
Yes. GCT is also one of the definition, but I think it is quite aggressive lesion.
Okay, sir. Thank you. Sir, Professor Maini, what's your opinion about this X-ray?
Before that, actually, as the age of the patient is 21, and earlier the onset of giant cell tumor, it is usually more aggressive, and this is probably a aggressive type of giant cell tumor.
Yes.
Yes, I think below the elbow, the lesions are rare, and we are used to seeing such aggressive giant cell tumors at lower end radius, especially when the age is around the second decade. And I would definitely keep a diagnosis of a giant cell tumor. Epiphyseal lesion, 20 years of age, and maybe on clinical examination, you would have a soft tissue mass in this patient due to a volar as well as a ulnar penetration of the tumor.
So, as a DD of all these things, I proceed for next MRI of this patient, and these are the MRI picture of the patient. This is another slide from this thing. Any comment from our radiologist?
Okay, so
Kaushik, from this clinical picture and X-ray and MRI, what do you think? Whether what our plans should be? Whether we go for directly core-needle biopsy, yeah, we go for the core-needle biopsy, PET-CT, all the things beforehand.
Considering the age after the skeletal maturity, though the particular specific radiological appearance, there is a trabeculated expansile thinning of cortex is not present here. There is typical very trabeculated expansile appearance of GCT is not present here. But this side, as you all know, is very characteristic for distal end of radius. GCT as a characteristic site, and Campanella stage 3 GCT can definitely have a extraocular soft tissue component, as evident also from the X-ray. So, and also from the MRI cross sections T2, I presume this is T2. T2 axial cuts, there is a solid component visible. There is no central necrotic components are not there, and ABC like changes are also not there. So I'll definitely like to have a pre-intervention core needle biopsy from the solid component to ascertain the histopathological diagnosis.
Okay. So core-needle biopsy was done, and it's a giant cell tumor. And
sir, I have one question.
Yeah.
Sir, what should be the tract of the core needle biopsy? Dorsum, volar, radial, ulnar. Because the extraosseous mass is mostly on the volar and the ulnar side.
So anybody, Professor Pal or Professor Mani will like to answer this question?
Looks like it's a giant cell tumor, and it looks like we can't salvage this joint. It seems to be going toward resection. More often, the surgical approach for resections is dorsal. So my preference would be dorsal, and I would examine the patient and would see whether dorsally I could get an area which is accessible for biopsy. My preference would be dorsal.
So my question to Professor Deepak Roy Chaudhary sir, do you have any experience of Brown's tumor? Though these are more common in the long bones, proximal humerus, proximal femur. Do you have any experience of Brown's tumor in this side, distal radius, distal to elbow and knee joint?
No at present, no at that side, but I have got one case of Brown's tumor in the
Sir, not audible, sir, your voice.
Humor. Is it now? Is it now? Okay, then leave it.
Hello.
If it is not audible, then you proceed for that. I'll talk to you later.
You are audible, but the voice is very low, sir.
Very low, but the problem is possibly in the jack that is not functioning properly. But if at all,
Not audible at all.
I not audible at all. Okay.
Okay, sir. I did.
See,
Yeah.
regarding bounce tumor, that usually take place in the shaft of the long bone in cortical bone, and it is well marginated. It is much more well marginated and very clear zone of transition. So it is not bounce tumor.
So corneal biopsy was done from dorsal approach, and it turned out to be giant cell tumor. My question to Professor Pal, Professor Maini, and Professor Rai Chaudhary regarding the plan of treatment, how to proceed, what sort of resection and reconstruction was be possible for this patient.
Actually, if the diagnosis comes as giant cell tumor, then my approach would be first therapy with denosumab, and after 1.5 months, the Kosik said it is 1 month. After a 1 month therapy, 4 doses, then the margins will be developed, and then resection of that part and reconstruction, maybe arthrodesis even in this particular case.
Resection and reconstruction with the fibula or with the...
Yes, fibula, upper end of the fibula.
Okay, sir.
Or as the case may be, or even arthrodesis if it is so required.
Okay, sir.
Reconstruction with fibula, it is preferred.
Professor Maini, what is your opinion about that reconstruction option?
I think denosumab is a preference for me in such a patient where I feel that the tumor is like blowing out like a balloon. It definitely improves the margins and resection possibility. And I used to do a lot of fibular replacement, but of late I am shifting towards ulnar translocation because the return to work is pretty fast for it and the outcomes are encouraging.
Kaushik, what's your opinion?
I prefer reconstruction will be on-work resection and ulnar translocation.
Okay. So I proceeded.
Because the fibula, if we are not able to reconstruct the wrist joint intercarpal ligaments minutely, then there may be either stability, too much stability may compromise the movement of the joint, or at the cost of stability, mobility, we may land up with a flail wrist joint. So my take will be towards the resection and ulnar translocation.
Okay. So I proceed in the same way. And
Professor Moitra, sir, TK Moitra, sir, do you have any opinion, sir? TK Moitra, sir. Sir, you have to unmute, sir. To unmute.
Arnav, unmute TK Moitra, sir.
I think some problem with his audio because I am not able to do this from here.
Yeah, I can't also. I am trying also, but Metro sir, I can't unmute.
I think some problem with his audio.
Okay. Hello.
You are audible.
Yes, am I audible?
Yes, yes,
sir.
yes.
Am I audible now?
Yes, sir. Yes.
Am I audible now?
Yes,
yes,
sir.
sir.
Yes,
You are audible, sir. Please.
Yes. I saw 2 patients of these types, both in NRS in 1980, in between 81 and 84. And in both these cases, it was giant cell tumor. Totally destroyed. Initially, we had an impression that it will be a malignant one. However, one was treated with the fibula, proximal fibula, resection and fibular graft, and intermedullary fixation. At that time, the implants were not much available in our custody. One was through the metacarpal, I fixed it with a K wire and massive bone graft, and it was followed up. There was some stiffness of the joint. It took up, and it was nicely took up, and I could follow that patient for about 2 years at NRS. After that, I was transferred, I do not know. And another case was treated with the ulnar. Ulna itself was taken as a graft and with the arthrodesis pattern. And that case was followed by me for about 6 months. And it was also, arthrodesis was achieved. And subsequently, I do not know. And the movements, finger movements, etc., hand function was acceptable. Restriction of pronation and supination. And these are my 2 experiences. Thank you.
So, can I proceed?
Yes,
Yes,
sir.
yes.
So, wide dissection was done with ulnar translocation. Before that, 2 doses of denosumab I gave because of cost constraint. I not able to give 4 doses. And intraoperative wide dissection with the dorsal approach is done. Dissection with the plate, arthrodesis. This is a follow-up X-ray, and the specimen was sent to the pathology for examination to Dr. Demolle. So I switch over to Dr. Demolle. He will have lots of comments. Demolle is available?
Yeah, thank you, Ananda.
Yeah.
So when I get the specimen, basically it was an in-block resection, and it is an almost solid gray-white tumor, and the margins, the gross resection margin, the resection margin grossly are free, and it was the closest margins was the 0.5 centimeter. And microscopically, it shows that there is a lots of the spindle cell proliferations, and the spindle cells are infiltrating the skeletal muscles. In these images, you can see that there's a lots of proliferating spindle cells, and there is a very few number of giant cells are there. Apart from that, there are the lots of, please next page, please, next image. Yeah. There are the lots of the osteoid formations along with the collagen depositions. So there's the spindle cells without any definite ATP and mitosis. There's lots of collagen depositions, and the osteoids. This all looks like that, like a low grade osteosarcoma. It's just look like a low grade osteosarcoma. So before giving the diagnosis, I just called Ananda ki any definite history was there. Then he told me that there is a history of giant cell tumor. I look on the previous slides. It was the nice giant cell tumor there, and there is a history of denosumab. So this history is very essential for a definite diagnosis, because the post denosumab, these all changes we used to get there. That is the no giant cells. There's a proliferating spindle cells. There's no ATP, without definite ATP and mitosis, and there is a deposition of osteoid and these collagens. So it's very essential to give a definite history. Otherwise, the pathologist mislead and give it the wrong diagnosis of the low-grade osteosarcoma. So I compare these histopathology images with the previous biopsy, core biopsy images. So there is a definitely giant cell tumor, and here this is the post-denosumab changes, and the margins are microscopically clear, and bone cut margins is free. Thanks.
So these are the conclusion words Dr. Demolle said to us. So it is very important about the history and clinical features and radiology sent to the pathologist for confirmation of the diagnosis. So this is the case presented by me. And I didn't put the follow-up X-ray, but follow-up X-ray and follow-up is excellent, and almost full range of motion, terminus, few degree of resection, but patient can able to do all the work from the right hand. So I put up the follow-up X-ray next page, definitely.
Thank you, Ananda.
Thank you, Dr. Demolle. Can I go for stop share? Any discussion?
Hello.
Yeah.
Hello, Ananda, am I audible?
Yeah,
Yes, sir, you are audible.
Yes. Can we go back to the X-ray again, please?
yeah. Sorry.
If we see the initial X-ray, the zone of transition was not narrow. It was a bit infiltrating sort of margin in this X-ray. But then the point against the osteosarcoma, if we go retrospectively, was the extensile sort of lesion. But then the margin was, margin was, I mean, not the zone of transition wasn't narrow. It was infiltrating sort of. We will look here. But then when we did the MRI, the margin doesn't appears to be narrow. It is. Can we see the MRI again, please?
Yes.
Yes, for coronal. But on MRI, it is very clearly seen that the margin are very much narrow. It is not infiltrating margin as it was appearing on the X-ray. So it is not an aggressive sort of, as the Maneda has said. It is more like a benign lesion, and GCT is more likely diagnosis. But X-ray was a bit misleading.
Yeah, that's why, sir, we always focus for the coronal biopsy for proceeding anything else. Yeah.
On X-ray, the other differential was telangiectatic osteosarcoma with that kind of transition zone.
Yes. Any comment from our faculty? Close this case. Kaushik, any comment?
Anand, one question.
Yes, sir.
Anand?
Yes, sir.
The question is, you have centralized the ulna, okay?
Yes.
And it is fixed with a plate.
Yeah.
So when you remove that plate,
I didn't have so much follow-up. I did one case 2 years before. Till now, I didn't remove any plate. I didn't see any literature where mentioned it is the plate is removed. So I didn't have any idea. Kaushik may say, Professor Lalit Mani can answer this question.
Sir, I have also never removed the plate. Yes, sir.
But what I have one publication on that issue, radialization of the ulna. In that case, the proximal some amount of movement of the intercarpal and carpometacarpal joint persist, and the wrist movement also persists. The radiocarpal, or in this case, it is the ulnocarpal movement, will be only restricted. So, if it is fixed by the Kushner's wear or something, it is definitely unstable much. But that movement of the intercarpal joint and carpometacarpal joints persists. That is my idea.
So any idea from Professor Lalit Mani of removal of the plate? When to remove? Yeah, when up to keep?
We are not removing the plates, and I think the literature also supports the same. However, we'll get to know in few more years whether it actually has any benefits.
Okay. So this is the end of this case. I stop here.
May I add your point?
Yeah.
Hello?
Yeah, you can add, sir. You can, yes, sir.
Yeah. I also think there is no need of removal of the plate, particularly nowadays the titanium plates are available. And there is a weakness.
That is titanium plate, sir.
And I will not recommend. And the patient which I asked later on Dr. N.D. Chatterjee, who followed that patient. I remember now, he also did not remove that plate, the single patient. And the patient was doing well, he told me.
Okay, sir. Thank you for saying.
Good evening, everybody, and senior teachers and colleagues. May I proceed, sir? Am I audible?
Yeah, Kaushik, you are audible.
Yes.
This is a 38-year-old male patient. He had a history of occasional knee pain since last 1.5 years. Intensity of pain increased since last 3 months. He went for a consultation to some orthopod for one of his friends and got his own knee examined by the sports injury expert and presented to our OPD with a MRI knee. He was advised straight away MRI instead of having a radiograph. He came with to our OPD with the MRI. So I am presenting the case as he presented to us. This is the MRI image. So Dr. Arif. Dr. Arif.
Yeah, Kaushik, I'm audible.
Yeah. Audible, sir. Please.
Hello.
Sir, you are audible, sir. Dr. Arif, you are audible.
Yes. Yes. So this is the, yes. Am I audible?
You are audible.
Yes. So we have one lesion in the distal femur that is quite well demarcated with narrow zone of transition. There is mild expansion of the cortex, but there is no cortical breach. There is no associated soft tissue. So it is a benign lesion, and DCT is.
Sir, voice a bit louder, sir.
Hello.
Yes.
Kaushik, now okay.
You're audible.
Hello.
Please carry on. Yes, you're audible, sir. Please carry on.
Yes, sir. So, well-defined lesion in the distal femur involving epiphysis and the metaphysis, a bit extensile with no cortical restriction, no associated soft tissue. Zone of transition is very narrow. Radiologically, it looks a benign lesion. GCT is a possibility.
Images, sir.
Audible?
Yeah. Please. So after the MRI, as per the protocol, we advise the patient to get an X-ray done. This is the X-ray.
Yes. Hello.
Yes, sir, you are audible. Please carry on.
Yes. So on X-ray, we are not able to make out we are not able to make out the lesion as such, except for I mean, X-ray is not that clear for the lesion, but MRI wise, it looks like a GCT. I mean, a benign lesion.
Dr. Deepak Rawachiduri, sir, do you want to add any comments?
Excuse me, can I see the X-ray again? Kaushik, can I see the X-ray again?
Yeah, sure.
Okay. So on X-ray, GCT should be a lytic lesion, but on X-ray, it doesn't look like any lysis in the bone.
Can you hear me, if at all? I can say that in the lateral view also it shows an osteolytic area in the femoral condyle.
What?
Not that It's not that definable. Can can we move on to MRI?
Yeah. It should have a contrast MRI.
Okay. Still, there is no. I was only suspecting there might be some, calcification inside, but there is no calcification. So I will say. So I will go with the GCT for this question.
The GCT means the classical description from plain X-ray is a trabeculated expansile lesion.
Yeah, expansile lighted lesion.
There is the classical description. It is not a, as evident from the X-ray, and also the internal trabeculations is also not there in the cortical region, which is appears as a trabecule. So from our doctor, as the impression from Dr. Arif, it appears like a well demarcated, less aggressive, benign kind of less aggressive kind of lesion.
One comment can I make?
Yes. Yes, Kashida.
It looks like a good exposure X-ray. The X-ray exposure appears to be good both in AP and lateral. However, it is a challenge the lesion is. So if in a good X-ray the lesion is not very clearly visible, I become a bit suspicious, and I define it as a very poor margin of differentiation from normal to abnormal. So I'm a bit worried whether this is a more aggressive lesion. Kaushik?
Yes, sir. The quality of X-ray is not up to the mark. The soft tissue and the bony contrast is not there. So I apologize for the quality of the X-ray. So, any further comments from the expert panelists, or we proceed with the next step? As per our protocol, we always do for any focal bone lesions, we do a coneal biopsy. These are the biopsy slides. So, Devmala, please explain your findings.
Am I audible?
Yes, you are audible.
Oh, see, basically in the there is a low power image and high power image also, and this shows that there is the lots of giant cells. They are benign looking giant cells. Apart from the giant cells, there are the lots of the very clear cells with a prominent nucleoli, and these cells have a very sharp cytoplasmic membrane. It look like a plant cell basically in actual descriptions. Apart from these, the giant cells and these clear cells, there is the benign osteoid and depositions and calcifications. So this is a very interesting case and rare tumor and challenging also. All these features, this presence of these benign looking giant cells, this bone trabeculae, these typical calcifications, and these clear cells with prominent nucleoli, they fit a classical diagnosis of the clear cell chondrosarcoma. Clear cell chondrosarcoma is a type of chondrosarcoma. It's a low-grade chondrosarcoma basically, and it's extremely rare. It represents almost 2% of the chondrosarcoma, and the location is also very classical for the clear cell chondrosarcoma. And apart from the classical chondrosarcoma, the clear cell chondrosarcoma used to appear in 1 decade before than there's its normal counterpart. And we use the IHC also. Next slide, please, Kaushik. Next slide. Yeah. So here he is getting that the tumor reach up to the epiphysis. So left-sided upper image, it shows the normal epiphysis. Yeah, this is the normal epiphysis, and tumor reaching up to the normal epiphysis. And rest of the images shows the presence of lots of benign-looking giant cells, the osteoid matrix. These are these are all benign-looking giant cells, and there's osteoid matrix formations, and these clear cells with prominent nucleoli. Next slide, please. Next slide.
Histopathology slides there.
Okay, so the core biopsy diagnosis is the clear cell chondrosarcoma. We use the IHC also. IHC's images are not there, and on IHC these clear cells is strongly positive for S100 protein, and they're negative for the DOG1. So we use this panel just to differentiate from the chondroblastoma. Chondroblastoma they're usually DOG1 positive, and the clear cell chondrosarcoma, they are DOG1 negative. But these are not essential. Basically, clear cell chondrosarcoma is a morphological diagnosis. But in spite of, I do this just for the academic interest and for the publication. So it's a diagnosis of the clear cell chondrosarcoma, basically. Thank you.
Well, so if we go back to the radiology, the X-ray and the MRI, what should be our proposed, after the diagnosis is confirmed, we have staged the patient with a PET CT, the patient is non-metastatic. What should be our surgical planning, sir? Lalit Mani, sir.
Oh. Well, this is a tumor which is managed surgically. It's not very tumor sensitive. So the challenge is to give a wide margin, and you need to sort of think, can you salvage this joint? Seems pretty difficult, and I think she'll end up going with a tumor process. Wide resection and a tumor process. Kaushik?
Your voice is not audible. Are you recommending en bloc resection?
Yeah, come again.
Sir, your voice is not audible, sir. Are you recommending en bloc resection and endo processes?
Yes.
Any other surgical planning from our panelists, sir? Deepak Rajchowdhury, sir, Jain Pal, sir, Professor Moitra. Any other planning? Any options for the biological reconstructions here? Dr. Garg?
Really want to salvage the joint. Maybe this is one area where a customized solution is exciting.
Considering the wide resection of the tumor, it's difficult to save the joint. And considering the all tumor oncologic margins, it's better to go for the resection and tumor processes.
So we did an en bloc resection, osteoarticular resection. This is the gross specimen. Deval, can you please show some light regarding the margin, the appearance on grossing and appearance of after fixation and the margin?
Yeah, sure. Am I audible?
Yes, yes, you are audible. Please carry on.
Oh, so the gross section shows the tumor, basically the gray white tumor, which shows the tumor is the soft tissue cut margins and bone cut margins are free of tumor grossly. Soft tissue cut margins, yeah. This left side, more left side, please. Yeah, these all soft tissue cut margins. The closest distance is the 0.4 to 0.5 centimeter, and bone cut margins are far away. Next image, please. Yeah, this is the IHC pictures, which shows that the tumors is nicely positive for S100 proteins, and these both are the S100 IHC, which shows the nicely positive in the tumor cells.
We did the IHC on the base on the final histopathology specimen after the resection specimen.
Yes, exactly.
This is the post-operative radiograph. We did a modular endo processes. Any comments from our senior teachers regarding the fixation, cementation, alignment, anything? Dr. Garg, Jyoti.
Anybody has experience on a biological reconstruction using a petla and a hemicondylar resection?
I don't have any experience. I have not seen.
Dr. Moitra might have.
Yes. We had some experience myself with ND Chatterjee, did some one cases. And so that the diagnosis was not like this, it was not chondrosarcoma. and that patient is still with in our follow-up for last 5 years. A wide resection, patella, graft with the patella and ilia crest, a huge graft was there, and it took off. And that patient is in our follow-up.
So, Kaushik, this was a lateral condyle or a medial condyle? Lateral condyle.
It was a lateral condyle, sir.
So now lateral condyle of femur makes it
Mine was also
that you
lateral
can
condyle.
think of a resection because there's no major ligamentous issue over here. And if you can maybe assess the tumor using 0.5 mm cuts on a CT scan, use either 3D printed jigs or use navigated systems, you can get a wide margin and do a hemicondylar resection. And with the advances of stabilizing these patellar grafts and getting fibular grafts or allografts, I think this option should be kept in mind because it's a challenging option. And if we can get wide clear margins, it's a good option, I think.
Means, sir, you are recommending a hemicondylar resection and reconstruction with an autograft, means a recycled autograft.
I think it's the Henneking's procedure in which they enucleate the patella and use the articular surface of the patella towards the knee joint. And on top of that, they put fibula and fix it with a plate or whatever you want to. Now, our fixation modalities have really improved. If we can use meshes of revision THR, the Exeter meshes, and do some impaction bone grafting on top of the patella, I think reconstruction is not a major challenge here. Probably it is a possibility. The only thing is that we need to really plan that we can actually get wide resection by doing thin slice CT scans.
So this will be arthrodesis, knee arthrodesis.
No. It will be a biological arthroplasty.
Okay. The patellar articular surface will act as a articular surface of the distal femur lateral condyle.
That's right.
I'll definitely read it, sir. I have no idea. So can we proceed to the next case, please?
Yeah, sure.
Yeah. This is the next case, a 10-year-old girl. Ankle joint since the 3 weeks. Difficulty in walking for the same duration. No history of any trauma. No history of any constitutional symptoms. So this is a plain X-ray. Dr. Arif, can you please show some light? Dr. Arif?
Yes. Am I audible?
Yes, sir, you are audible.
Okay, so
this is the history 10-year kids. Yeah.
Okay.
That is
first,
this is sorry to interrupt. This
November
is November 2019 and this is January 2020.
Yes.
Yes, sir, please.
So we have lytic sclerotic lesion with moth-eaten appearance in the fibula involving long segment of the fibula with associated lamellated sort of periosteal reaction. It is an aggressive lesion, and considering the eosinophilic granuloma, Ewing's round cell tumor, and Ewing's is the most likely possibility for this patient. And we can see the extensive progression between the November and November 2019 and the January 2020. So it is fast growing lesion, aggressive lesion, like a malignant sort of. The other definition, not maybe the lymphoma is also a possibility, but I think it is Ewing's cancer.
Hello, am I audible?
Sir, you are audible, sir. Please.
Yes. Hello.
Yes, Dr. Arif.
Yeah, just as I explained, it is an aggressive lesion with moth-eaten appearance, multiple holes in the bone. Yeah, everything is a possibility.
This lesion is apparently looking like chronic osteomyelitis, but but in this X-ray, there is multiple lamination.
Your voice is not audible, sir.
Voice is disrupted.
So
There might be some network issues.
Yeah, nothing is audible.
Dr. Deepak Roy Chaudhary, sir, any comments on the X-ray, sir? Dr. Deepak Roy Chaudhary, sir?
From X-ray, Kaushik.
We can't hear.
Sir, you have to unmute yourself. Yes.
Even then, I am not audible. Maybe very feeble. Can you clearly listen to me? Might be some problem in the linkage.
Your voice is not audible.
If not audible, I cannot say anything at present. But my first thing should be on chronic osteomyelitis, if at all is audible.
Kaushik, from short history, first diagnosis should be having a round cell tumor. Second would be the chronic osteomyelitis, in my view. Because the history is very short in 3-month duration. It's too much differentiate. There is a periosteal reaction, onion pill appearance, all the things is there. So first thing should be a malignant one.
What is the blood fixture here?
So the blood picture was essentially normal.
Normal. ESR is normal. CRP normal.
The reports are absolutely normal.
Everything is all.
So we proceeded with the cross-sectional imaging. Dr. Arif, these are the MRI images. I apologize for the poor quality of imaging. Dr. Arif.
Yes. Yeah. Can you see the axial images?
Yes.
Contrast. Do we have contrast images?
These are the images available to me right now.
Okay. Looking at these images, we have some amount of associated periosseous soft tissue. There is some breach of the cortex here as well, and then we have the periosteal reaction. Okay. So now it might be osteomyelitis as well, with maybe the intracortical abscess and sinus formation in the bone with associated soft tissue. If we could have a contrast, then it would have been clinching for this patient for making diagnosis, for making the diagnosis.
Specific points which can differentiate the infection from the aggressive neoplasm based on the MRI.
Yes, if we would have the contrast images, and if we can see the axis, then it would have osteomyelitis. But then we don't have contrast images, so it is difficult now. But it still can be effective.
Yeah. So we proceeded with the biopsy, core-needle biopsy. Dr. Demal, please explain the biopsy slides.
Sheets of blue cells with very little matrix. Large nuclei and no cytoplasm.
So the diagnosis was given as a chronic osteomyelitis. This case. So there is a great mimicker of aggressive neoplasms, aggressive bony neoplasms. So the take-home message from this case was the infection should always be kept as a close differential for aggressive bone lesions. And we should always culture what we biopsy, and we should always biopsy what we culture. There is a principle that holds good to avoid any confusion regarding the diagnosis. In this case, what sort of intervention, if at all required, should be advised for this patient, sir? Professor Jain Pal, sir, what is your advice? Is a chronic osteomyelitis in a 10-year-old kid. Asymptomatic means only pain, is the only symptom. Professor Mani, sir, any advice regarding the further course of action from the treatment point of view?
So we'll try to assess the pain, and if it is too much for a 10-year-old child, maybe splint the limb, give rest for some time, give some anti-inflammatory, should settle down.
Any role of antibiotics, IV or oral antibiotics, sir?
No, not really.
Or any surgical intervention?
No.
So these are the two cases that I had to present in this meeting. So Arnav.
Yes.
Yeah, that's where we conclude.
Yes.
Thank you all the expert panelists, all our senior teachers, Professor Lalit Mani sir and all our senior teachers for participation, Professor Demal, Dr. Demal and Dr. Arif especially.
Yes.
Hello.
And special thanks to Professor Mani sir from West Bengal Orthopedic Association to take time to participate in this meeting and enrich us with the knowledge. And I'll request Chinmay sir to say the concluding remarks so that we can end the meeting. Chinmay sir, are you here?
I think Chinmay sir, no, sir is not here.
Okay, then Rajiv, you can.
Yeah. So thank you, Kaushik, for wonderful bone tumor registry meeting. And if I can see on it, in last bone tumor registry meeting has been viewed by more than 506 people. So record attendance on bone tumor, and this was also very good. Interesting cases were presented by Dr.
Rajiv.
Yeah.
I'm here. Rajiv.
Oh,
yes,
Chinmay sir, please. Yes, sir.
Yes. So it makes a few comments.
Yes, sir.
First one is that biopsy, there are three methods. One is bone needle biopsy. Other one is the excision biopsy. Start with cases biopsy also. And giant tumor has got more reason about the recurrence. So demosunum, it is not a panacea. It has got some selected use. When you plan for the subacute lesion, benign lesion, when you plan for the curative and grafting or other filler, then only we should go for Nebuchadnezzar. In any other cases, usually the use of Nebuchadnezzar is not required. Very costly and useless. And regarding the management, as advised in most of the cases, in our country, it is not suitable because in the young giant cell tumor is basically a disease of the young group, active group. So the reconstruction with the arthroplasty is not desirable because they have to walk for a long time. Sometimes they have to carry the weight. So arthrodesis, tumor around the knee joint, arthrodesis is the treatment of first choice. And regarding the management of giant cell tumor of lower end of the radius, actually, as said by Koshi, it is not the joint will fail, it is not that. You reconstruct with the upper end of the fibula, reconstruct radial coronal ligament, and most of the cases we have the stiffness, the fibula is no flail joint. And when we opt for the centralization of the ulna, it is a treatment that it is sort of arthrodesis. So it is this joint is stabilized over the ulna. So no need of plate, whether it's steel plate or platinum plate, no need of removal of the plate because it is fixed in the functional position of the rotation of the forearm and it is stabilized over the ulna. And unicondylar, as rightly said Professor Maini, because it is not very difficult approach to have done lot. When the single condyle of the tibia or fibula is affected with the giant cell tumor with maintenance of the articular cartilage, it can be usually reconstructed by using the patella and some degrees of movement of the knee joint is maintained. So I think this is all about the additional knowledge about the management of giant cell.
Thank you, sir. Thank you. I think Lalit Mani sir has also same view regarding arthroplasty.
Thank you so much, everybody. It's a pleasure to attend this tumor registry. I have myself attended this registry in 2006 in Calcutta with Professor Matra himself. And it is always a pleasure to be a part of this registry. Thank you so much, Rajiv and Kaushik and everybody.
Thank you.
Thank you, sir.
Thank you, sir. Thank you. Yeah. All right. Now we will end the meeting.
Yes.